Our next section is acute pulmonary edema, where we will define it, talk about the presentation and the tests and the treatments of this disorder. As a matter of definition, what's the difference between pulmonary edema and congestive heart failure? Well, pulmonary edema is the worst form of congestive heart failure. If congestive heart failure makes you short of breath, this makes you more short of breath. If congestive heart failure makes you accumulate fluid in your lungs and edema, this makes you accumulate more fluid in your lungs. It's just simply the worst version of it, and one that always equals admission to the hospital, always equals transfer to the emergency department, is never managed at home. Pulmonary edema is simply the most life-threatening version of congestive heart failure. How do I answer their question? What's the most likely diagnosis? Well, Helen Keller could make this diagnosis. It's acute shortness of breath with rales, jugular venous distension, S3 gallop, edema, orthopnea, paroxysmal nocturnal dyspnea. I'm drowning! And sometimes people can get a lot of ascites and fluid overload in the belly, and enlargement of that big liver and big spleen, big hemorrhoids, and passive congestion of the liver on the right-hand side. It's a severe, overwhelming, acute shortness of breath from congestive heart failure. In some people in whom you're not certain, what is it from? Could it be pulmonary embolus? That's what we have the BNP, the brain natriuretic peptide, for. It's only when the diagnosis is not clear. And an elevated BNP is not too specific. A normal one excludes congestive failure. An elevated one helps us hardly at all. We're doing it to make sure it's not normal, because normal excludes. The chest x-ray will show, let me guess, it'll show pulmonary edema, vascular congestion, cephalization, because most blood vessels are filled towards the bases. When it fills up from the bottom up, goes towards the head. Cephalization, it fills up like a cup of water from the bottom to the top. That's because normally most flow is at the bases because of gravity. Now, enlargement of the heart will be there if it is chronic enough. If you had pulmonary edema from an acute disorder that didn't have time for the heart to enlarge, it's possible you could have it with a normal-sized heart. Most of the time, though, you will see a dilated cardiomyopathy, a big heart dilated in all directions, but especially to the left. When it is there for a long period of time, you will have an effusion. The chest x-ray that is more sensitive for an effusion is it the lateral or the PA, the lateral or the posterior anterior. The one that is most sensitive for an effusion is the lateral. The lateral x-ray can detect 50 or 75 milliliters of fluid, whereas the PA film needs 200 or 300 milliliters of fluid just to even see blunting of the diaphragm. Well, you remember when we said cephalization of the flow? Well, look at that. See those arrows there pointing to all those big white things going up and down like that? There they are. Those are those extra engorged veins. The oximeter and arterial blood gas will show hypoxia. They are not indispensable to the diagnosis. In other words, if a person comes in and they're described as being acutely short of breath, rales, edema, and jugular venous distension, the blood gas doesn't add a whole lot to that. It is the most accurate way to be able to determine the oxygenation, but it's not indispensable. Just remember that in order to hyperventilate enough to get oxygen, the usual finding in pulmonary edema is a respiratory alkalosis. Because when you're hyperventilating, carbon dioxide leaves more easily than oxygen enters. So you should expect to see hypoxia, an increased AE gradient, and respiratory alkalosis. If you see a respiratory acidosis or CO2 retention, this person, first of all, you should question the diagnosis. Number two, the person is likely to be near intubation. This question that says, which test is most likely to alter acute management, is more important than the oximeter question. The person comes in, they're breathing fast, and they say, I'm short of breath. What does the oximeter add? Hey, you're short of breath. You're hypoxic. Well, I know I was hypoxic. What are you going to do differently? Nothing. A person comes in, they've got Ralls to the rapaces and jugular venous distension. The chest x-ray shows vascular congestion. What will you do differently based on the chest x-ray? The answer is nothing. So what test will you do something different on? And the answer is the EKG. If the EKG shows atrial fibrillation, atrial flutter, ventricular tachycardia, what would I do differently? Well, that answer is a huge difference. If you developed pulmonary edema from an arrhythmia, you're hemodynamically unstable, and the fastest way to fix hemodynamically unstable arrhythmias is with electricity. Chest pain, shortness of breath, hypotension, confusion means you are not getting enough perfusion, and shock them back into sinus. And when you get that atrial contribution back, your pulmonary edema may very well resolve. A normal heart only derives 10 or 20% of its cardiac output from the atrial contribution. But a diseased heart needs more of its atrial contribution to maintain the cardiac output. A normal person can live without their atrial contribution. They can have AFib forever. But if you have a leaky heart from valve disease, you need the push. If you have a weak heart from cardiomyopathy, you need the push. And when you lose that atrial contribution, now instead of losing 5 or 10 or 15%, maybe you're losing 30 or 40 or 50%. And all of a sudden, boom! The diseased heart, you get flash pulmonary edema with the atrial arrhythmia. The diseased heart means a dilated cardiomyopathy or bad valve disease. And if pulmonary edema is from an arrhythmia, you fix it fast with shock, electrical cardioversion. Which of the following is the most accurate test of congestive heart failure? And the answer is echocardiography, provided a MUGA scan is not there. MUGA scan is the most accurate method of looking at ejection fraction, but echo must be done on all patients. It is the only way. It must be important. It's in capitals. It's the only way to determine systolic or diastolic dysfunction. Now, initially, when a person comes with an acute pulmonary edema, that doesn't change acute management. It's still preload reduction. Preload reduction for acute pulmonary edema. Oxygen, diuretics, nitrates, and morphine. However, in long-term management, it makes a huge difference in therapy because of the drugs that we can use for systolic dysfunction. ACE, ARB, beta blocker, spironolactone. So echo must be done, but not for acute pulmonary edema. A 74-year-old woman comes to the emergency department with acute pulmonary edema. Respiratory rate, RR's respiratory rate of 38 a minute. Remember, normal respiratory rate is about 12, 14. 20 is not normal respiratory rate. Now, you may see that in your rotations. That's the nursing falsification rate. Okay, but 38 is well over double a normal respiratory rate. Ralls, trapecies, jugular venous distension, S3 gallop. In other words, this is not a diagnostic question. We're giving it to you. Hey, here's pulmonary edema. What do you want to do about it? Here's pulmonary edema. What do you want to do about it? And the answer is diuretics, oxygen diuretics. Now, oximetry, see, this is exactly the point. The oximeter here, what difference does it make? You know that this person needs oxygen and diuretics. What difference does it make? Sure, you should do an oximeter. But what's the most important thing? Oximeter is good. Hey, and you go, hey, listen, hey, lady, you're hypoxic. And she goes, yeah, that's what hey, oh. And she turns blue and drops dead. It's like, yeah, that's what I told you. That's why I came to the hospital. I can't breathe. Now you tell me I can't breathe. What difference does it make? The echocardiogram should be done, but it doesn't make a difference acutely. ACE inhibitors are an excellent drug, but ACE inhibitors don't change anything for acute pulmonary edema. Now, it seems contradictory because the initial management of pulmonary edema is based on drugs that don't change long-term mortality. Diuretics and nitrates, morphine, don't change long-term mortality. But acute pulmonary edema is based on a mechanical transfer of fluid from the vascular space to the toilet. Long-term management is hemodynamics, ACE, beta, ARB. Nesiritide is an artificial form of giving you atrial natriuretic peptide. That's what nesiritide is. It is atrial natriuretic peptide. It is a synthetic atrial natriuretic peptide because ultimately it actually was a great idea. It just doesn't help too much. So there's no mortality benefit. So when you see it, nesiritide is one of those drugs that can be used. It's like dobutamine that is used to relieve symptoms in acute pulmonary edema without mortality benefit. Nesiritide is artificial atrial natriuretic peptide. Acute pulmonary edema management is very straightforward. Oxygen diuretics, nitrates, and morphine. Oxygen diuretics, nitrates, and morphine preload reduction will lead to the resolution of 90% of cases. Do not confuse this with drugs that change long-term mortality. Take a liter of fluid out of the lungs and mechanically remove it, put it in the vasculature, pee it out, and put it in the veins. Preload reduction for acute pulmonary edema. This management was the same 40 years ago, is the same right now. Well, the majority of people with acute pulmonary edema can manage with just preload reduction alone. You remove the fluid, and the nesiritide doesn't help a whole lot more than the others. Just remember is that preload reduction is all you need. Most people don't need to go to the ICU. Most people don't need dobutamine or amrinone or milrinone. They just get better with that simple preload reduction. The patient gets preload reduction, they get oxygen diuretics, nitrates, and morphine, and they're still short of breath. What is the next best step in the management of this patient? Well, the positive inotropic agents we use, without necessarily lowering mortality, are dobutamine, amrinone, milrinone, which are phosphodiesterase inhibitors. They increase contractility, they decrease afterload, and we use them. I didn't say they lower mortality. I just said we use them acutely in an intensive care unit, and we use them for that small number of people, not better with preload reduction alone. Now, the most common wrong answer is digoxin acutely. Digoxin is way too slow. It takes weeks to try and increase that contractility. It's the wrong answer. It's high yield because it's the wrong answer. Because it has no benefit in acute setting. It's the wrong answer in acute setting. Ladies and gentlemen, remember, congestive heart failure is present in hundreds of thousands of people. If you do your studying simply from the point of view of only trying to get a bunch of answers on test questions, it's not as powerful as saying, hey, look at all the cool stuff we can do for people. Look what we could do in 1975 or 1980. Diuretics that made you hypokalemic, and then the hypokalemia caused digitoxicity. What could you do? Virtually nothing. Look at the cool stuff we could do now. ACE and ARBs lower mortality used on discharge. Isn't that cool? You have systolic dysfunction, they make you live longer. We use nitroprusside in the ICU very temporarily. And if you really can't take an ACE and an ARB, we use hydralazine. And we use it with nitrates because we don't want it to steal blood from the coronaries. And remember, heparin is just useless for acute pulmonary edema unless you have clots. But look at all the cool stuff we can do. It's a great time to be in medicine.